Hello and welcome. I'm Jeunesse Castonguay, VP at Clarius. We're thrilled to see so many of you join us here today. You're among 1,800 clinicians who registered for the live webinar, Cardiac POCUS Part 1, Techniques for Assessing Left Ventricle Function. Research confirms that clinicians can miss subtle signs of heart failure in emergency environments, which can significantly increase patient morbidity, mortality, and length of stay. In a moment, emergency physician and ultrasound educator, Dr. Tom Cook, will join us and present several cases demonstrating how to use point-of-care ultrasound to assess left ventricle function in patients presenting with chest pain, dyspnea, and unstable vital signs. He'll share 4 easy tools we can use to reliably determine whether the left ventricle is pumping adequately and how to choose the best management plan. You'll learn practical POCUS skills you can use on the very next day in an emergency department, in a hospital ward, or intensive care unit. You can use the questions icon at any time during today's session to ask questions, which we'll address in a live Q&A at the top of the hour following the presentation. Let me now introduce you to your host for today's webinar. Dr. Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as chairman of our medical advisory board. Welcome back, Dr. Frankel.
Thanks, Jeunesse. It's great to be here and with a topic that's near and dear to my heart with a fellow emergency physician. To set the stage for today's talk, we did a broad literature review, and I wanted to just review a couple articles to kind of set Dr. Cook up on our perspective on using point-of-care ultrasound for cardiac cases particularly. The first paper I wanted to bring to was a broad systematic review that really emphasizes how focused echocardiography can provide rapid guidance with very high fidelity data on patients' cardiorespiratory function, which fills in the details that we need as clinicians on the clinical context, which is especially useful in patients where we need rapid answers. Either their diagnosis is unknown or their clinical presentation has suddenly changed and we need to modify our treatment or diagnostic trajectory. Specifically also in patients presenting with cardiac conditions, we know that they represent a very high risk category, and quick answers are of utmost importance for these patients, sometimes where we really need those answers in seconds, sometimes in the emergency department, but also the ICU, perioperative environments, or even on a hospital environment, or sometimes even in the primary care clinic settings. And just to kind of hone in on one specific technique that we'll be reviewing more in depth is E-point septal separation, which has been shown as a really effective screening tool for monitoring and calculating left ventricular ejection fraction in a lot of patients. And it's been shown to be quickly learned by not only emergency physicians, but also anesthetists. And we're sure this can expand and scale out to hospitalists and other practitioners with really not that much skill required to do these advanced calculations. Before we dive in a little bit more into the deeper topic on how to assess left ventricular function, we wanted to put out this poll. We see there are a lot of you from all over the world in different walks of practice, and to see where are you coming from? How frequently do you use ultrasound to assess left ventricular function in your clinical practice? Are you just learning today? Is it something we rarely do, or something monthly, weekly, or even daily? Maybe every shift or every time you're at work. And since it's a pretty quick poll, we'll probably close this out here in a second. And we can see where folks are. And great, so we've got a large span, a lot of beginners here joining us, which is excellent. So we have a lot to share and a lot to teach you and some experts. We think there'll be something here for everyone in today's talk. And we can't think of anyone better to bring in than Dr. Cook. Dr. Thomas Cook, after leaving active duty with the U.S. Army in 1996, joined the faculty of the emergency medicine residency at Prisma Health in Columbia, South Carolina. And soon after, he founded Third Rock Ultrasound, an education company designed to help all healthcare providers integrate ultrasound technology into their practice. And over the last 2 decades, Third Rock has presented course on over 1,500 occasions throughout the United States, as well as Europe, Africa, and Asia. And since 2001, Dr. Cook has also been the program director for emergency medicine with Prisma Health and University of South Carolina School of Medicine. It's such a pleasure to have you here in the first of our series. Dr. Tom Cook, we're going to hand it over to you.
Thanks, Aran. It was a really wonderful introduction. I hope I can live up to the hype of all of that. As Aran said, I am a practicing emergency physician. In fact, I worked pretty late last night and had a lot of sick patients and had my ultrasound on my side the entire evening. So it really is something that I use every day at work. Laurent also mentioned that I'm the founder or one of the co-founders of Third Rock Ultrasound, and we've been teaching healthcare providers for almost 25 years now, and I'll hopefully have some time to circle back and tell you a little bit about what we do with Third Rock, and maybe some of you would be interested in joining us for some education. But we'll start off our talk today with a pretty typical case. Everyone sees this, certainly in an emergency department setting. It's an old guy with abdominal pain. And he also mentions to you that he's had some rectal bleeding. And, oh, by the way, my doctor says I have heart failure. So, you get your initial set of vital signs and you see he's tachycardic and hypotensive. So you realize that this patient is in shock. And you get an initial hemoglobin back of 5.7. So immediately you're starting to think you need to volume resuscitate this guy with some blood. But of course, you have this lingering story of heart failure. And of course, this is very common on our patients as well. So you think to yourself, maybe I need to assess this guy's heart to see if he can, take an aggressive fluid resuscitation. And this is the picture you're left with. And during the course of the next 30 minutes or so, I'm going to give you 4 very simple tools to quickly evaluate the heart so you can make a determination about what the next best step in this patient's management is. In addition, you have to ask yourself, can this guy's heart take it? Here are the 4 tools that we're going to provide for you over the next 30 minutes. These are all things you can do at the bedside and really only take a few seconds to half a minute of your time. And the first tool we're going to give you is a myocardial thickening. So when you talk about myocardial thickening, you have to ask yourself, what does normal heart muscle look like? And it looks like the same as any other muscle in the body. Every time we contract a normal muscle, it does 2 things. It's going to get shorter and it's going to get thicker. And if we look at these 2 examples right here, the patient on the left, we've got this big, strong arm, this big, normal muscle. And we see here in the interventricular septum of normal heart muscle that every time it goes through the cardiac cycle and contracts, it gets shorter and thicker. This is very, very easy to see. While on the right, we have sort of a spindly arm, a weak arm, and we see that in the interventricular septum of this patient. It really doesn't shorten much at all as it goes through the cardiac cycle, and it certainly doesn't get thicker, particularly in this section of the muscle.
Which arm is yours, Tom? The right or the left?
Mine is definitely the one on the right. Yes, it used to be the one on the left as a young fellow. Now we're looking at the parasternal long axis view, obviously. And when we look at the patient on the left and we look at the interventricular septum, it's pretty clear that this muscle gets shorter and thicker as it goes through the cardiac cycle. We can also see that in the posterior wall here as well. When we move to the right, what we see is that this interventricular septum doesn't move very well at all. And we can also see that in the posterior wall as well. So this is pretty easy to pick off just by looking at it. So let's look at this case right here. On the left, what we see, the muscle, the interventricular septum, is actually pretty thick, but if you look at it closely, it doesn't really shorten or get thicker during the cardiac cycle. And when we look at the patient on the right and we look at the interventricular septum, we do see that muscle does get shorter and thicker as it goes through the cardiac cycle. Let's look at another example, but this time we'll look at the parasternal short axis view. Now it's the patient on the left, when we look at the septum, that we don't see any evidence of shortening or thickening as it goes through the cardiac cycle. But on the right, we do see evidence of this as it goes through systole. All the muscle in the left ventricle getting shorter and thickening and moving towards the center of the chamber. This is an apical 4-chamber view, and it's very easy to see, particularly if you look at the apex of the left ventricle on the left. You can easily see how that muscle contracts and gets shorter and thicker, while on the right, you do see really an absence of any contractility at all. So really, the first tool that I gave you is very, very simple. You're just going to be looking at the heart. You're going to be looking at the heart muscle to see if it contracts. There's no measurements involved. There's really nothing else. And this is just something that you're going to pick up with time. Now we'll move on to the second tool. And this is called mitral valve excursion. And so initially you may ask yourself, what does the movement of a valve have anything to do with judging the function of the left ventricle? And we can start this part by actually cutting through the heart on the left. And what you see on the right side of the slide is that plane where we sort of cut the heart in half. And when we do this, we see that the pulmonary valve is the most anterior valve. The aortic valve is in the center. And in the posterior part of the heart, we have these two atrioventricular valves, which are the largest valves in the heart. In fact, the mitral valve is the largest of all four valves. And it's also unique because it only has two leaflets. It has a very, very large anterior leaflet and a relatively small posterior leaflet. And it's this anterior leaflet that's so easy to pick up on ultrasound. So here we have a parasternal long axis view, and we can see that the anterior leaflet is very, very easy to see as it moves through the left ventricle. And you pick that up over here without any problem at all. We can also see that in the parasternal short axis view. Again, the anterior leaflet is right here. It opens up and it comes into contact with the interventricular septum. So this structure is very, very easy to pick up on ultrasound, and this is really something that even relative beginners can do. Now let's talk about a little bit about the physiology of a normal heart. So when we have a normal heart or normal left ventricular function, at the end of diastole, the pressure in the chamber is very high. And this makes sense because at the end of diastole, the chamber is full of blood. Then in the normal heart, as we go through systole, we're going to eject the majority of that blood that's in the chamber. So in this case, a normal ejection fraction of 60%, the majority of the blood is going to be sent out of the heart through the aortic valve into the aortic outflow tract. And then at the end of systole, we know that the relative pressure in the left ventricle is low because we've ejected the majority of the blood. We can contrast that with somebody who has left ventricular failure. So once again, just as with a normal heart, at the end of diastole, the pressure is going to be high because it's full of blood. But in this heart, it's failing, and it's only pumping out about 10% of the volume of the left ventricle during systole. And therefore, at the end of systole, the relative pressure in that chamber is high as compared to the normal heart. So with all this explanation, you may ask yourself, what does any of this have to do with the fact that we're trying to figure out what the ejection fraction is, and how does this have anything to do with what's going on with the mitral valve? Well, you have these three variables which play against each other. You have left ventricular ejection fraction, left ventricular pressure, and mitral valve movement. So in the normal heart, at the end of systole, we know the left ventricular pressure is relatively low. And that sets up a big pressure gradient between the atria and the ventricle. And that allows a large quantity of blood to move from the left atrium into the left ventricle. And when this happens, the valve has to open all the way for this to happen. Therefore, if we see the mitral valve open completely, we know that the ejection fraction is high. This is a normal heart, and you can actually see the anterior leaflet very well, and it opens up completely and actually makes contact with the interventricular septum.
And do you ever call it the septal slap?
Yes, absolutely. It slaps the septum. Here we have a parasternal short axis view, same thing. We can see the anterior leaflet. It moves very aggressively and makes contact with the interventricular septum. And this is normal. And this tells us that left ventricular function is normal. Now let's talk about the failing heart. Now we know that the ejection fraction is low, and therefore the relative pressure in the left ventricle at the end of systole is high. So in this situation, the pressure gradient between the left atrium and the left ventricle are pretty close, and only a small quantity of blood will be able to move across the mitral valve, and therefore the mitral valve will not open completely. Therefore, we know when the mitral valve opens partially that the ejection fraction is low. And so here we can see an example of that, where we look at the anterior leaflet, and it doesn't even go halfway from the closed position up towards the interventricular septum. So that gives us information that the ejection fraction is low and left ventricular function is low. We can look at another example here in the parasternal short axis view. Again, what we see is that the anterior leaflet doesn't move anywhere close to touching the interventricular septum. No septal slap, as Aran would say. And this tells us the ejection fraction is low and left ventricular function is low. Now, as a rule of thumb, what you can do with this mitral valve movement is essentially say that if the anterior leaflet makes contact with the interventricular septum, you have a normal ejection fraction of about 60%. If it moves halfway between the closed position and touching the septum, you have a moderate amount of left ventricular failure, so an ejection fraction of somewhere between 30 and 40%. And then finally, if it only opens a little bit from the closed position and doesn't even go halfway to the interventricular septum, you have a severe degree of systolic dysfunction at less than 30%. Now, You may ask yourself, can I measure this? Can I quantify this actual movement of the leaflet? And you sure can. And this is called EPSS, E-point septal separation. And Iran alluded to this in the very beginning of the webinar. This is a very easy thing to do. You can do it in the parasternal long or the parasternal short axis, and it only requires a single measurement. There's no math involved. It's just basically looking at it and recording a number. So the way we get started with this is we take, in this situation, a parasternal short axis view, and we take the M mode cursor so that it passes through the tips of the valve leaflets of the mitral valve. When we do this and we look at the M mode image, we see that the y-axis is depth and the x-axis is time. And we have two anechoic areas on the screen. The one closest to the transducer at the top of the screen represents the right ventricle, and the one that's deeper is the left ventricle. Now, we can also see when we do this is the movement of the two valve leaflets within the left ventricle. And you can see them right here. This one closer to the anterior surface is the anterior leaflet, and this one down here is the posterior leaflet. We can also see other structures in this image. This line right here represents the free wall of the right ventricle. This one represents the interventricular septum. And finally, the one at the bottom of the screen is the posterior wall of the left ventricle. We can also see that when we have these two lines here that represent the valves, when these two valves are farther apart, that tells us that the valve is open. And we know that if the valve is open, that we are actually in diastole, which is what we're going to be interested in here. And when the two valve leaflets are close together, that tells us that we're in systole. Now, we're talking about movement of the anterior leaflet. So now we're going to focus our attention just on this waveform right here. This is the movement of the anterior leaflet in the cardiac cycle. And during diastole, we get two pronounced waves. And you will see this in any normal heart and certainly most diseased hearts. The first wave is called the E wave, and the second wave is called the A wave. Now, I'll start with the A wave. What happens with the A wave is that as the left ventricle starts to fill up and the pressure begins to equilibrate between the atria and the ventricle, the valve starts to shut. And right near the end of diastole, the atria contracts, it squirts a little bit more blood through the valve, and you get another brief opening of the valve before it closes in systole. So that atrial contraction is called the A wave. The first wave is called the E wave for early diastole. And that's that point in the cardiac cycle where there's a big pressure gradient, the valve opens up completely, and you can see that represented here as this E wave approaches the interventricular septum. And this E wave is what we're going to focus our attention in, because that E wave is the E and EPSS. So there are 4 steps to getting the EPSS measurement. The first one is to get an adequate parasternal long or parasternal short axis view. The second one is to go ahead and take an M mode cursor and run it through the tip of the anterior leaflet of the mitral valve. The next one is to go ahead and set up your M mode tracing so that you can identify the mitral valve. And then finally, what you'll do is go ahead and measure the EPSS, which is the distance between the E wave and the interventricular septum. And you can see right here that in this example, it's a little less than 3 millimeters. And the system actually calculates an ejection fraction of about 70%. Here we'll be able to see the entire exam as we go through it with a real patient. So we have a parasternal long axis view. Then we're going to go ahead and deploy our M mode and place our cursor right through the tip of the mitral valve. And you can see here that we've got a really nice tracing of the anterior valve leaflet. We'll go ahead and deploy EPSS measurement and measure from the septum down to the tip of the E wave. And when it does this, we're going to get a measurement of just around 8 millimeters with an ejection fraction of approximately 56%. As a rule of thumb, when the EPSS is 8 millimeters or less, we know that the ejection fraction is normal, or about 55%. When we have an EPSS of about 8 to 18 millimeters, the ejection fraction is 30 to 50%. And when it's greater than 18 millimeters, the ejection fraction is less than 30%. Now, here we have an example where we can look at the heart and we can see pretty quickly that the mitral valve leaflet doesn't go all the way up and touch the septum. So we'll go ahead and put our M mode cursor through that and quickly go ahead and get our tracing. And when we do this, we can identify the E wave and the A wave. Then we'll go ahead and measure that distance, and we'll see it's around 13 millimeters with an ejection fraction of about 44%. Let's take another example. We'll look at this one here in the peristernal short axis view. So we can clearly see the anterior leaflet of the mitral valve. We'll go ahead and get our M mode tracing, and then we'll go ahead and identify our E waves and A waves. And we can see right away that the E wave literally touches the septum. So there's really not even a reason to measure this, because we know that the E point septal separation is normal. Here's another example where we clearly see that the anterior leaflet of the mitral valve does not touch the septum, but we'll go ahead and measure that distance anyway, just to determine what the E point septal separation is. We can see right away that the E wave anterior leaflet doesn't come anywhere close to the septum. And when we measure that, we get a distance of 19 millimeters with a very low ejection fraction. Now, there's several limitations to using E point septal separation that we need to sort of mention at this point. And if you don't do this, you can tend to overestimate or underestimate the ejection fraction if you're going to use this. The first one of those is atrial fibrillation, because the position of the anterior leaflet of the mitral valve is incredibly variable, and you really can't use it because you don't have coordinated movement between the atrium and the septum. So for atrial fibrillation, EPSS cannot be used. But here's another example. We have a lot of septal hypertrophy, a really, really thick septum. The anterior leaflet seems to touch it, but because the septum is so thick, it can allow you to overestimate the ejection fraction, because the septum, or rather the leaflet, doesn't have a normal distance to move to give you an indication of the quality of left ventricular contraction. Here's another example where we look again and we see that the anterior leaflet really doesn't move and completely touch the septum, but we're also seeing that the septum itself does appear to shorten and thicken as it goes through the cardiac cycle. This is one of those cases where you could say, well, it seems to be moderately impaired. We have some moderate degree of dysfunction. This is one of those situations too, where maybe what you need to do is look at the entire heart and make sure that you don't make a mistake. Because in this particular situation, this patient has a lot of apical akinesia. And even though there is some moderate degree of left ventricular dysfunction that you see in the peristernal long axis view, when you go to the apical view, you see that it is in fact much worse. And so this wall motion abnormality has to be taken into account, that, or you will overestimate the ejection fraction of the left ventricular function. So with all this said, I've given you two tools, right? I've given you myocardial contraction, and I've also given you EPSS. But, there's another thing that we have to ask ourselves here is, like, can we actually measure left ventricular contraction? Can we actually measure how well the muscle contracts? And this is a little difficult to do with the heart because it literally moves in an infinite number of planes. But to simplify this, let's just look at it in two planes. We'll look at it in the axial plane and in the longitudinal plane. So the third tool of the four tools I'm going to give you is axial contraction. Now, just to define that, the axial plane is going to be perpendicular to the long axis of the left ventricle. And it helps us if we simplify our thinking of the left ventricle and turn it into a cone. And of course, when we think about this cone, this plane right here is the axial plane. And this is what we'll focus on for this third tool. And when that left ventricle contracts, the muscle gets much, much thicker. And of course, the diameter or the distance in the axial plane shortens. So when we extrapolate this to a peristernal long axis view, we can see on the left that it's at the end of systole, and this dimension is quite large. And then we can look at it at the end of systole, and we see that it's quite a bit smaller. And that's what we're interested in evaluating. We want to see how well the heart contracts in that particular plane. So here we are looking at a peristernal long axis view, and we get a real nice look at this dimension, this axial plane that we're interested in seeing. We see that it actually looks very, very normal. We see that the interventricular septum and posterior wall really approach each other quite aggressively. Let's look at it in another case. Now, in this particular situation, when we look at the axial plane, wow, it really doesn't move well at all. And this gives us an indication that the contraction of the left ventricle is very poor in the axial plane. We can also do this in the parasternal short axis. Again, we're interested in the diameter of that chamber, or the measurement in the axial plane at the start and the end of systole. And when we do it here, we can see it in a normal heart, where we see that all the walls of that left ventricle move towards the center. So there's a dramatic change in the diameter of the chamber as it goes through the cardiac cycle. By contrast, we can look at it in this particular heart, and we'll see that this is very poor. This heart has very poor contractility in the axial plane, and therefore we have left ventricular dysfunction. Now, there's also this component where we can actually quantitate the degree of contraction we have in the axial plane, and that we're going to use a tool called fractional shortening. And it's really very, very easy to do, but it does require one additional measurement, one more measurement than we got with EPSS. We again can do this in the parasternal short or the parasternal long axis views, and it does require you to enter the numbers into one simple equation. So there's a little math here. Now, once again, we're going to get a parasternal long axis view. We're going to take our cursor, we're going to put it through the left ventricle, but we're going to be off the mitral valve a little bit. We want to be away from the tips so we get a much more clean picture. And as before, the anechoic area in the anterior part of the image, closer to the top of the screen, is the right ventricle. And then we can also see it down here in the left ventricle, where we see this change in the width of the chamber, and that's what we're actually interested in. As before, when we talked about the mitral valve, as the chamber is getting larger, we know we're in diastole, and as that chamber is getting smaller, we know that we're in systole. And so what we want to do is measure these two distances at the end of diastole and at the end of systole. So here's an example of how we would do that. We get an adequate parasternal long axis view, and we'll go ahead. And just to make it simple, I'm even just going to use a vertical measurement. You can actually go into the menu and choose left ventricular end diastolic and left ventricular end systolic, but let's just use a simple vertical measurement. And we get our first measurement at the end of systole, and it's about 41 millimeters. And then we'll get our next measurement at the end of diastole, and it's about 56 millimeters. Now, we're going to take those two numbers and put them into a very simple formula, and that is the difference of those two measurements divided by the longer measurement and multiply by 100 to get a percentage. And in this particular situation, when we take 56 minus 41, which is 15, and divide by 56, we get a fractional shortening of 27%. Now, what's normal? Normal fractional shortening is 25 to 45%, and you really have to be careful not to confuse that with ejection fraction. Ejection fraction is normally between 55 and 65. Fractional shortening is much lower than that. So don't confuse those two terms. Let's look at another example. Here we can see the left ventricle again, and our end diastolic measurement is 52 millimeters, and our end systolic measurement is 38 millimeters. So we have a difference of 14. We can plug that again into this formula, and we end up with a fractional shortening value of 27%. Here's another example. Once again, we can see that at the end of diastole, it's 39 millimeters. At the end of systole, it's 27 millimeters. So we have a difference of 12 millimeters, and we calculate our fractional shortening at 31%. Here's another example. Now, when we look at this one here, we can see that the septum seems to bow in or move towards the center of the ventricle. So it might be easy for us to think that, hey, this probably has normal fractional shortening. This guy probably has normal contractility in the axial plane. But if you did that and you didn't actually measure fractional shortening, you might get kind of fooled on this one. And here you can see in the M mode with the cursor, you get this very interesting pattern where the septum moves in and out, but so does the posterior wall. And when you do this, you see that there's not really a big difference between the distance of those two structures in both systole and diastole. And in fact, the difference between the two is a very, very small number, about 1.5 millimeters. And when we plug it into our actual formula, we see that it's only 4%. This person has terrible left ventricular function with regard to contraction in the axial plane. So sometimes you have to be a little careful and not get fooled. What you're seeing is essentially a very abnormal heart, but you're only looking at one part of it. Here's another example where we got our cursor through the left ventricle, and immediately what you see is there's almost no change in the diameter of the left ventricle. And so when we go ahead and even try and measure that, we see the difference is so small, we don't even need to put this into the formula. We know that fractional shortening is very, very poor.
it might be worth emphasizing, each of these, you're giving all these different tools, they all work together. Like you mentioned, not focusing on one specific part of the heart to miss the rest of it, but really looking at all the tools together gives you the holistic picture. They should all add up to the same
Absolutely
picture.
right. And you beat me to the punch as we will tie all this together shortly. So the last tool is longitudinal contraction. You can see that here. This is in the long axis of the left ventricle. And again, we'll go back to this idea. We think of the left ventricle as a cone. And now we're interested in the contractility in this particular dimension, the long axis of the chamber. And as before, we'll recognize that when the left ventricle contracts, the muscle gets thicker. So therefore, the chamber gets shorter. And it's this particular measurement or this movement that we're interested in with our fourth tool. Now, we have to recognize that when we look at it on ultrasound, the actual apex of the heart doesn't move at all. It's the base of the heart that actually moves towards the apex. And we can see that in this particular video here. The apex is actually fixed and the base of the heart is down here. And it's the base of the heart that is moving towards the apex. Now, here we're looking at two examples. The one on the left, we see again, the apex of the heart does not move. And this is normal. But when we look at the base of the heart down here, what we really see is that there's really almost no movement of the base of the heart towards the apex. By contrast, when we look at the heart on the right, we can see that we have the base of the heart moving towards the apex of the heart. And this is obviously much more normal than the example on the left. So can you measure this? Can you quantify this degree of moment? And of course, the answer to this is yes. And we use a tool called MAPSE, which is an acronym for mitral annular plane systolic excursion. And it's very, very easy to perform. Again, it's one simple measurement. There's no calculations, and you just have to do this in an applicable four-chamber view. There's no math at all. You're just going to get a measurement. And the way that we'll do this is to look at the base of the heart. And remember that the base of the heart contains the mitral valve, and the mitral valve is held into place by something called an annulus, which is a piece of very, very stiff fibrinous material, and it's very echogenic and easy to see on ultrasound. And so what we would like to do is evaluate the motion of this mitral valve annulus as it makes its way towards the apex. We want to measure that. That is MAPSE. And there's 4 steps to get this. The first step is to get an applicable four-chamber view. Then we're going to go back into M mode again, and we're going to take our cursor, we're going to put it through the lateral aspect of the mitral valve annulus, and then we'll evaluate that particular image under M mode. And we're interested in this waveform right down here. We want to see that waveform as it moves up and away from the apex of the heart. And then finally, we'll go ahead and measure from the trough of that waveform to the peak, and we'll get a number. Now, here you see an example of how this is done. We've got an applicable four-chamber view. We're going to turn on M mode. We're going to take the cursor, we're going to put it through the lateral aspect of the mitral valve annulus, and we get this waveform, which is very, very easy to see. Then we'll go ahead and freeze that image. We'll go into our measurement menu and go ahead and choose MAPSE, and we'll put one cursor in the trough of that waveform, and the second cursor will go on the peak. And we'll see that we get a measurement of 17 millimeters. Again, so what's normal? Well, normal for a male is greater than or equal to 13 millimeters, and normal for a woman is greater than or equal to 11 millimeters. How about this heart? So we look at it right away and go, wow, that thing looks pretty sad, doesn't beat very well. We can look at the apex and see that it doesn't really get thicker as it goes through the cardiac cycle. The apex doesn't seem to move very much. And the mitral valve leaflets don't seem to open all the way during diastolic. But all that aside, we can also look at this annulus over here and say, how far does that move? So let's go ahead and get a MAPSE measurement. Here we have the cursor going through the lateral annulus. And we can see that the waveform, first of all, is not very dynamic. And when we measure it out, it's only 4 millimeters. So this is somebody who has very poor systolic function based on MAPSE. So we've gone through all these 4 tools. Remember, it's myocardial thickening, it's EPSS, it's axial plane contraction using fractional shortening, and it's longitudinal plane contraction using MAPSE. But we also have to recognize that there are pitfalls to using these tools, and you need to be aware of them. One of the questions that often comes up with people, they say, is it better to measure these things and do some sort of quantitative objective analysis, or is it better just to look at the heart and make a judgment? And as with most things in life, it's usually sort of a combination between the two. That you'll look at it and also do some measurements, and you'll figure out with time when you need to rely on one strategy more than the other. It also depends, obviously, on the degree of experience of whoever the examiner is, the type of ultrasound system you're using, and also the clinical scenario, what's going on with the patient at that particular time. The other thing to keep in mind about all of these 4 tools is that you're using essentially linear measurements to describe a 3D structure. And it can set up situations where you'll get inaccurate information if there's regional dysfunction, like that wall motion dysfunction I showed you earlier. There's abnormal geometry to the valve from some pathologic process, or there's some type of valve pathology. But what's really nice, and what Aran was talking about earlier, is you can actually look at the heart, think about the 4 tools we've talked about, and make a very, very quick assessment of left ventricular function. So let's just take an example of this as a parasternal long axis view. And immediately our eyes are drawn sort of to the anterior leaflet. It is so easy to see, and it waves around. And it goes up and actually makes contact with the interventricular septum. So you know that EPSS looks good. And from that, you can say, well, left ventricular function is probably really good. The other thing you can do is you can look, of course, at the interventricular septum for myocardial contraction or myocardial thickening. And once again, we see that the septum gets shorter and thicker as you go through the cardiac cycle. And the same can be said for the posterior wall. The other thing we can do is look at the axial plane, the degree of shortening we have in that plane as you go through the cardiac cycle. Of course, it's quite dynamic. So you say, well, look, axial contraction is very good. And then finally, you can look down here at the annulus of the mitral valve and see how it moves towards the apex. And you see that it does make a motion towards the apex. So once again, that tells you have good systolic function. You didn't have to do any measurements with this, right? You just had to go through those 4 tools in your head. And that usually takes somewhere in the order of about 30 seconds or so if you're examining a patient at the bedside. Let's look at this case. Now, when we look at the septum, we see it's thick, but we see that it actually doesn't get any shorter or thicker during the cardiac cycle. It appears to just be frozen in space. When we look at the anterior leaflet of the mitral valve, we see that it only opens maybe halfway, maybe not even halfway. So that's 2 points of that's 2 of our 4 tools that tell us that there's something wrong. When we look at the axial plane, we do see some movement, but it's not very, very dramatic. And so it probably leads us to believe that there's poor left ventricular function. And then finally, we can look down here at the lateral aspect of the mitral valve annulus, and it moves a little bit, but it's not very dynamic. So again, I'm just using those 4 tools without doing any measurements. I'm just running them through my head, and it gives me a pretty good idea that this person has very poor left ventricular function. Here's another example. Now, if you just look at the one on the left, you can say, well, that valve doesn't open very well, but I do see some thickening in the base of the septum right here. It does get shorter and thicker. Maybe that's okay. And I certainly see some movement in the annulus of the mitral valve. It does move towards the apex. I do see some thickening of the posterior wall. So there seem to be some things that say that the systolic function's reasonably okay. It's just the anterior leaflet movement of the mitral valve that's abnormal. But this is that case again, where when you look at it in the apical 4-chamber view, you see that the entire apex is out. And so this would lead you to underestimate. You can go through those four tools, but it's always important to take a couple different views and look out for those things that might pop up that you didn't think were there just based on one view. Now, this is a case that becomes very important, and Ron and I had discussed this earlier, but obviously a parasternal long axis view. And if we look at the interventricular septum, we see that it gets shorter and thicker. So this gives us good information about function. And we look at the posterior wall of the left ventricle, and again, the same thing, it gets shorter and thicker. But when we look at the mitral valve, the anterior leaflet, it only goes about halfway. And that tells us that the left ventricular function is not good. We can also look at the diameter or the axial plane and see, wow, that ventricle actually moves pretty well. Those 2 walls are moving close together. And finally, we can look at the annulus of the mitral valve and see that it moves towards the apex of the heart. So you have a conflict here. You've got 3 tools that are saying, hey, it looks pretty good. And then you have The only tool that doesn't say it looks good is mitral valve excursion. And this is a case where you have to think, particularly in older patients, that maybe what you have is a valve problem that's giving you bad information. In this situation, we'll go ahead and turn on color flow, and we see this patient has aortic regurgitation. And this is not an uncommon problem in older patients who have hypertension. So here we can see what's going on with aortic regurgitation. On the left, we have the valve opening completely and early diastole, and all the blood rushes into the left ventricle. So the anterior leaflet makes contact with the septum. But with aortic regurgitation during diastole, there's a jet which limits the movement of the anterior leaflet, so it only opens partially. Nonetheless, the chamber is still filling adequately, and so ejection fraction is still pretty good. Left ventricular function is still pretty good. So now we can go back and look at it again and say, yep, that anterior leaflet doesn't move so well, but in fact, the left ventricular function is good. You have a valve problem. What about HFpEF? This is heart failure with preserved ejection fraction. In the old days, we used to call this diastolic heart failure. And this is a situation where you have a really stiff left ventricle, thus abnormal diastolic filling, but you still have a preserved ejection fraction of greater than 50%. All of the tools that we discussed today have really no basis for measuring diastolic failure. They're really just looking at systolic failure of the heart. Are there any other ways to measure ejection fraction? Well, certainly there are. One of the ones that you will hear about the most is something called the Simpson method, which is also called the biplane method of discs. Now, this is a fairly complicated measuring tool where you trace the endocardium of the left ventricle at the end of diastole and the end of systole in both the apical 4-chamber and the apical 2-chamber views, and then you put it into a calculator that spits out an ejection fraction. But this is typically something you see on higher end machines, and it involves spending a lot more time at the bedside than typically we'd want to do in a clinical setting. So we've gotten to the point where we can circle back to our opening case. And we had this situation with a guy who was in shock, who had bled quite a bit, and we were concerned that, we wanted to volume resuscitate him with blood products. And we went ahead and got our ultrasound, and this is what we see. So immediately we've learned now that we're going to look at his interventricular septum, and we see that it doesn't really get short or thick at all. It just kind of moves. And we can go ahead and look at the anterior leaflet of the mitral valve and see that it only opens about halfway. So 2 of the 4 tools I've given you right away are abnormal. So that should tell you there's a problem with left ventricular function. We can also look at the axial plane of the left ventricle. It doesn't seem to change very, very much. And we do get some movement of the lateral annulus of the mitral valve towards the apex, but it's not incredibly impressive. We can go ahead and measure EPSS, as you see here. It's pretty clear that the E wave comes nowhere close to touching the interventricular septum. We can go ahead and measure fractional shortening. And once again, we've seen this earlier in this lecture where we see movement of the septum, but in fact, the diameter of the chamber doesn't change much at all. And so this is evidence that we have poor left ventricular contraction in the axial plane. We can go ahead and measure MAPSE. And once again, we see this number is very small, only about 4 millimeters. And again, you saw this earlier within the lecture. So we know right away that this patient is not doing very well. He has very poor systolic function. And this alters our plan dramatically because we cannot aggressively volume resuscitate this patient because we'll probably put him into volume overload and then be dealing with pulmonary edema and some other problems. So we need to be very, very careful about how we resuscitate this particular patient. Just a couple of final thoughts, and I'm going to turn it back over to Iran. I gave you 4 tools. They're very, very easy to use. They're very easy to remember. It takes really not that much time to learn this stuff. And as with anything in life, you'll get better with practice. You simply look at these hearts and start running those 4 tools through your head. And before you know it, you become quite a bit better at judging a left ventricular function. I also want to, just as I close up here, just put in a shameless plug for Third Rock Ultrasound. We, as I mentioned before, have been going for about 25 years. And our next open course will be this January in Park City, Utah. If you can believe it, when you actually see it, it's much prettier than the picture. We've done this course for well over a decade. It's extremely popular. It's the largest ski resort in North America. There's lots of trails like this, which are for me, which are really easy to ski and groomed. And then there's the really steep stuff for all the crazy people. So really skiers of any skill set can go out here. It's great for beginners. It's the perfect place to learn how to ski if you haven't done this already. We do this course at the Hyatt Centric in Park City. It's absolutely beautiful there. It's a wonderful place to hold a conference, and we've been there now for 7 or 8 years and just had a spectacular time. The introductory course is January 9th through 11th, and the advanced course is the 11th and 12th. And we set this up so we do lectures in the morning, then you ski all day, and then you come in for the evening to go to training labs. So as I said, it's extremely popular. Otherwise, I want to thank everybody for their attention, and also thank Clarius for giving me the opportunity to present this material to you. And I'm going to turn it back over to Aran.
Thanks so much, Tom, for the great content. I see people are already using the Q&A, and I encourage you to keep filling it. We'll have time to get to your questions at the end of our presentation here, so please keep using that. For now, I'm going to hand it over to Shelley Gunther, our clinical marketing manager, for a quick demonstration on acquiring some left ventricular views.
Thanks so much, Aran, and great presentation, Tom. Lots of great videos.
And I see your patients in left lateral decubitus there, Shelley?
Yeah, that's right. I always like to have my patients in left lateral decube when I'm especially looking from the parasternal long axis. And the reason is it just brings the heart a little bit closer to the chest wall. You tend to get a little less lung interference and just better overall imaging. So what we're seeing here, just a nice parasternal long axis, and we're looking for that axial contraction of the left ventricular wall here. And so what we're seeing is the septum here and the posterior wall back here. And here's our mitral valve right here. I'll just try and get that a little bit nicer. Great. So we can see that the mitral valve, when it's open, is coming pretty close to the interventricular septum. I can go ahead and turn on the M mode here. And what we can do is just drag the M line over to the mitral, the tips of the mitral valve here. And we're just getting a nice trace.
Yeah, it's important, like what you're doing to really get it to the tip. You can imagine if you don't get it all the way to the tip, your EPSS will calculate lower than you want it to. So you want to give them the best chance. Yeah,
you'll be selling your patient short.
Right.
So I can just go ahead into the EPSS.
Sorry, which is again why it's nice to use all 4 of those tools, because you can be off a little bit on one, but the other 3 may make up the difference.
Right. Mm-hmm. So I've measured from the peak of the A wave and to the septum in systole here, and I'm getting an EPSS measurement of just under 9 millimeters, which is fairly normal, maybe tiny bit reduced, but pretty good overall function from what we can see from eyeballing the mitral valve as well as doing that measurement. And the other thing we can do is just have a quick look at I can put the M line over the interventricular septum, which is here, as well as the posterior wall. I'm going to move that line out just a little bit. And freeze again. And again, I can go into the measurement package. Tom, you did kind of a mathematical calculation. I'm basically lazy, so I'm going to let the machine do the math for me and measure the left ventricle in systole and diastole. And here I'm getting a nice fractional shortening of almost 29%, which falls within normal limits as well.
And it gives you an estimate of the ejection fraction there already, right?
Yeah, exactly. Yeah.
Cool.
Yeah, our ejection fraction is right here. Great. So mildly reduced. I do know my patient has had an LAD obstruction in the past and had a stent put in. So he does have some reduced function, but just mild.
Not a surprise. That's good.
Yeah.
Awesome. Well, thanks for that, Shelley. That's great. We have a lot of questions coming in, and so we want to get to those questions really briefly, and we'll field them with Tom. First, we're going to hand it back to Janez.
Thanks, Aran, and thank you, Dr. Cook, for sharing your 4 easy tools with us today. Thank you also, Shelley, for the fabulous live demo. Before we open up the floor to live questions with Dr. Cook, here's a quick poll. We'd love to help everyone continue their journey in bringing ultrasound guidance to their practice. So please do let us know if we can provide further information. Do click on as many options as apply. Pricing and availability does vary by region, so do feel free to request a quote and pricing. You may opt to speak to one of our experts about the advantages of wireless ultrasound. You may be interested in discussing the scanner features and booking a one-on-one demo with our clinicians to see Claris HD3 in action in an interactive session. We do have a number of scanners, including a multi-purpose C3 and the PA for superb cardiac imaging. So you can see both of those in action if you'd like to book a demo with us. We can also send you more video tutorials from our Claris classroom. So please go ahead and select as many options as you wish with this live poll. While you do that, I'll take a minute to introduce you to Claris HD3, the world's only third-generation line of portable ultrasound scanners. Now 30% smaller, lighter, and more affordable, Claris delivers best-in-class wireless ultrasound imaging with an easy-to-use app that's powered by artificial intelligence for your Apple or Android devices. Our line of Claris scanners are specifically designed to deliver best-in-class imaging for a variety of applications. And today we focused on the phased array for superior cardiac imaging. With fast frame rates, the Claris PA HD3 is amazing for rapid cardiac exams at the bedside. With a small footprint and deep imaging, the PA delivers high-definition window into the chest and abdomen up to 40 centimeters. It's a leading choice for medical professionals looking for premium cardiac imaging in a versatile handheld scanner, also capable of EFAST exams, lung evaluations, superficial and transcranial imaging. Artificial intelligence, specialized presets, and customizable workflows automatically optimize imaging for a seamless experience. And the secret lies in each scanner with not one or two, but 8 beamformers, 192 elements, and artificial intelligence that together deliver the image quality only found in traditional systems, but at a mere fraction of the cost. And with AI replacing complex knobs and buttons, it's as easy to use as your smartphone. Claris is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings. It fits in your pocket, and you get free movement with no wires getting in the way and touching your sterile prep area. With no wires, Claris is also much faster to clean, disinfect, or you can fully encase it in a sterile bag. Only Claris delivers wireless scanners with an ecosystem that includes free apps for your iOS and Android devices for unlimited users. Available with our new membership, Claris Cloud is used to easily capture and manage unlimited exams from anywhere, or you can seamlessly save images and videos to your PACS server through the current DICOM web standard. Your membership also includes in-app Claris videos with experts like Dr. Cook and onboarding with a clinician. And Claris Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. Available with membership or as a standalone purchase, the new Primary and Critical Care Advanced package offers more flexibility for users who need additional automated tools and workflow solutions for common generalized scanning for fast, EFAST, and whole body imaging. It includes the popular Auto Preset AI feature that streamlines workflows by automatically recognizing the anatomy being scanned and switching to the most optimized preset, automatically delivering the best imaging. We're now going to close off the poll in 3, 2, 1. And thank you. If you ask for more information, we will get back to you in the coming week. We have one more poll. We'd like to invite you to pre-register for our next webinar in our series with Dr. Cook entitled Cardiac POCUS Part 2, Techniques for Right Ventricle Function. Please complete this poll to pre-register for our February 16th webinar, and we'll send you a confirmation email in the coming weeks. I'd like to welcome back our clinicians to answer your questions. So please use the questions icon in the menu bar to ask your questions. Dr. Frankel, I'll invite you to moderate.
Thanks everyone for sticking around, and let's just jump in. So Dr. Cook, first question, this often comes up, is how to get better. You talked a lot about image interpretation. How can we get better, or the participants get better at image generation?
Well, this goes back to sort of the last slides in the presentation, which is practice. I often, being a residency director and have residents that come up, I don't know how to do this. And I said, well, you know how you get better at that. And they kind of hang their head and go, I guess I have to practice. Of course, it's nice if you have somebody there who can act as a mentor or as somebody who can guide you through the process. But a lot of people don't have those resources. So for them, if they're a beginner, and a lot of people are beginners, that's where you're probably getting into some sort of introductory course, so you understand how to set up and hold the machine and get those initial images. And then once you do get those initial images, you just scan everybody that you possibly can. And I guarantee you will get better. If you scan 100 people, you're going to be way, way better at the end of that process than when you started out. So it's just learning the basics and then just going for it. And you'll be shocked with how much you learn in a very, very short period of time.
100% agree. 100%. We'll jump into some more content. This comes up also with when I teach a lot, and in our clinical scenario in the emergency department, or maybe pre-hospital, or in the operating or perioperative environment, or in the critical care, like a lot of our patients, we can't get into left lateral decube. So do you what's your approach to that? If you can't really get them into the left lateral, how do you do your imaging?
I sometimes have to take pieces of all the different areas that I examine and put them together in my head. And that skill set obviously comes with time. So you can see how the left ventricle functions in one particular view, or how the right ventricle functions in another view. Maybe that's subcostal. And so you have to be willing to take different parts of the images that you can acquire and put them together in your head.
Yeah, I will echo that. Those calculations you showed are specific to those views. Like that's where they're validated, right? So EPSS is validated in the long axis, but not in the other views. So,
well, I mean, you can do it in the short axis. You can do it in the short axis
right.
too, because essentially it's the same thing, just flip 9 degrees. But it doesn't work for apical, and it doesn't work for the subcostal views.
That's right, right. So yeah, you have to bring other tools if you're generating the other view. You have to know which tools fit with which view, and how to kind of bring those all together, like you said. So what do you do? Like, do you have an approach? I mean, I think we kind of answered this in the way, but a lot of people want maybe a reiteration, or if we can reframe it of, how do you integrate that information? If you can only do you do only like 1 or 2 estimations, or do you really try and do all 4 in all patients? Or are there more that you didn't allude to that you add in your summative assessment of each patient?
So I'm probably rephrasing it, but I said sometimes in medicine, we have to take what we can get. And there are just limitations, whether it's the patient has a limitation or the scenario. I was in a resuscitation last night of cardiac arrest. There's 12 people in a small room, and you can reach over and only get so much between the chest compressions and so forth. But you can get essentially valuable information, even though maybe you can only use 1 or 2 of those tools to get an assessment. So that becomes a big part of the equation, and you'll learn with time, and particularly some of the other webinars we're going to have on right ventricular function in the spring, and then later on next year on resuscitation, that there are other things you can look at besides the heart, which give you information about the heart. And so you start pulling in all the other assets and all the other tricks that you acquire over time to help you make a management decision. I mean, that's what this is about. We go to the bedside and we want to know, what do I do next? And so sometimes you have to use bits and pieces and put them together, just like we do with any patient evaluation. We use a little physical exam, use a little lab, use a little ultrasound. We put the whole piece together and come up with an idea of what we need to do.
Yeah. And so can you speak a little bit more, that hopefully this will address some of the questions here, about what are some of the clinical situations where you find cardiac ultrasound the most helpful? You showed an example case of a patient in shock who needed a blood transfusion, and you were trying to figure out, okay, how do I approach, the resuscitation element, the volume resuscitation? But where are other places where you find cardiac ultrasound really helpful?
Almost anybody who's got chest pain or shortness of breath, which obviously is in, a very high percentage of patients that we see in the emergency department. It could be a young man who has shortness of breath, and everybody goes, he's just, this or that, or he can't possibly be sick, and his EKG looks fine, and his chest X-ray looks okay. And you go and look, and you realize, this guy has pulmonary hypertension. Or it could be the older person who comes in and says, I just get a little more tired when I walk to the mailbox. And you go and you see that they've had this insidious onset of left ventricular failure. Or maybe they have some other valvular process that's forcing them into this. And so it is absolutely the number one tool for these complaints, and you see them all the time. I mean, for Christ's sake, if you're still using your stethoscope, what are you doing? That's 250 years ago. It doesn't work. Put it away. This thing comes out of your pocket, and in 30 or 45 seconds, you've considered 6, 7, 8 really important diagnoses that you have to do when you're looking at these patients. And so just about anything. If I'm in a critical care area of the emergency department, I'm probably using it on 60 or 70% of my patients.
Yeah, I'd echo that. And I'd echo also, specifically around vital sign abnormalities as well. So Yeah, any clinical concern in the chest, basically, or if anything's going on with the vital signs, like you kind of alluded to with your case, to help you assess what's the next best step, because we don't want to cause harm. So often we rush, 4 liters of IV fluids or something is like some people's, go-to, and then, you cause a new problem. The person's in pulmonary edema because they couldn't handle it.
I had a gal last night who came in and she was AFib RVR. And so the first thing everybody wants to do is run over and slow her heart down. Oh, give her some diltiazem or something. Let's slow her heart rate down. It's too fast. Her pressure's soft. Well, what I didn't ask her is what you've been doing the last few days. And it turns out she'd had some vomiting and diarrhea. So when you actually go and look at her intravascular volume, or IVC, is very, very flat. And it's like her heart isn't going fast because she's got a bad rhythm. Her heart's going fast because she's dehydrated. And if you slow her down, you'll kill her. And so, again, it just goes into those things. We get in these mindsets about, we anchor all the time on what we think we should do in the first 30, 45 seconds. And just, look at a couple more things and go, oh, well, wait a minute here. The trick is not rate control. The trick is volume resuscitation. So it cuts both ways, right? You got the case I had. This guy, you don't know if you should volume resuscitate him or how fast. The other one is like, oh, I need rate control. Like, no. You need volume first.
Yeah, and there's papers, I didn't go over those from the cardiology literature, that either unrecognized congestive heart failure at admission, or the fluid, just the reflex of giving people IV fluids who have CHF. Both of those have a real mortality effect on inpatients that are captured in large database studies out of cardiology. And so what we do really matters in terms of patients' cardiac function and how we treat them in the ER, because what we do, everyone kind of anchors on also, and it sort of sets up this chain of command, chain of events.
The classic now, of course, is sepsis. Everybody's got sepsis coming out of their brain, and we're constantly vigilant about finding people with sepsis. But if somebody you think has sepsis, the first thing you should do is see what their heart function is, because most of these patients, or a lot of these patients, are old. And so their heart doesn't, you don't know what their heart looks like if they're 70 years old and they're on a sepsis protocol. You better go look first before you throw in 30 cc's per kilogram of fluid.
That's right.
You might end up with a much bigger problem and have them on a vent. So again, it's imperative when you have these sepsis, just go look. It only takes 30 seconds. And you can go, okay, I feel fine. Give them lots of fluid.
Nice. A couple more quick questions if I can squeeze them in. Do you ever do diastolic assessments? Is that something in your wheelhouse?
Of course. Yeah. I mean, they're for two reasons. I mean, the biggest reason is you have right heart failure, in particular isolated right heart failure. And the most common thing we see in an emergency setting is pulmonary embolism, a large pulmonary embolism. So of course you have to consider that because the treatment for that is exactly opposite of volume resuscitation. If you have acute right heart failure, oh boy, you give them a bunch of volume, you'll kill them. And we'll talk about that, in the springtime when we go into that. It's exactly the wrong move. But, it's hard to pick up diastolic failure. It's not an easy diagnosis to make at the bedside for somebody who hasn't been there before. And there's just a couple of little tips, we'll talk about in the springtime that keep you from making that mistake.
Nice. And how often are you actually doing the measurements versus eyeballing? I mean, I would consider you probably an expert at this point. So, maybe not a fair.
I'm an eyeballer. I'm very much an eyeballer because it's fast and I've seen a lot of them. I'll do the measurements more as in a teaching scenario just to demonstrate that there's some math behind the madness. But
math behind the eyeball.
Really, over time, it becomes very easy to say. The one, and you and I have talked about this before, the one you get fooled on is the one with the aortic regurgitation, right? That's the one where the valve, because everybody anchors on that anterior leaflet. They anchor on the mitral valve. Oh, we love that. It's fast and it's quick. But you can get burned on that one if you're not carried, because those people can take lots of volume. You don't have a problem with that.
Right. Yeah, it's important to keep all the tools in the box, not just one. Well, we want to be respectful of people's time. We tried to answer as many of these questions as we could, and those that we didn't, Janez will be getting back to folks and trying to fill in the gaps here.
Yes, thank you for all your questions. We've had dozens and dozens. If we didn't get to your question, we'll follow up with you by email in the coming week. There was a lot of interest in receiving a copy of the recording. and lots of fabulous comments, Dr. Cook, about your presentation. So want to let you all know that you will receive a PDF copy of the presentation as well as a link to the webinar recording, and we'll make that available in the coming days and send it to you by email. So do keep an eye on your inbox. I'd like to conclude by thanking Dr. Cook for sharing all of his best practices, and a very, very big thank you for all of you for joining us today. We hope to see you again for our next webinar on February 16th with Dr. Cook on cardiac POCUS techniques for assessing right ventricle function. In the meantime, have a wonderful rest of your day and keep scanning. Thanks so much.
Thanks, everybody.
Bye,
Take care.
everyone.